evidence derives by the OCT that we have a long lesion. We have marginally 180 degrees of calcium in some parts of it, and at least in our point of view, had some nodular calcifications or calcified nodules, if you like. There is some some bilingual approach in the bibliography. You have shown all that, but we didn't have uncrossability. That's roughly for sure, at least for a semi-compliant balloon. We had eccentric calcium, and that's true. We had a little bit of a depth where it was when we were able to estimate that. And we have a thicker than 1 millimeter of calcium, so we opted in for orbital atherectomy. Calcified nodules are the new kids on the block. We are very sensitized to search for them, but we don't know if there is any difference among eruptive or non-eruptive calcified nodules. There is another nomination by Professor Guglielmi as nodular calcification versus calcified nodules, where there is a rupture of the endothelial surface. And we did orbital at the end of the day. You can see, you cannot see because it's very slow orbital atherectomy as opposed to the pecking motions of the rotation, the classical atherectomy, the rotational atherectomy. And we have a significant sound change when there is the tight stenosis, and that is indicative for this method of a tight calcium, and that was a good feeling for that. And at the end, you can see the crown at the proximal part of the vessel. We had a good lumen, but with some opacification here that complies with thrombotic burden. So we went for the post-orbital atherectomy imaging. Professor.
Let's go back to OCT.
Can we go back to the OCT? Okay. Here we are at the point. So here is what we call protruding nodular calcification. This is after orbital atherectomy, supposed to be 80,000 in terms of spin.
Yes, not 120.
Okay. No, and you started to see something that, number one, let's have an idea about the lumen. The lumen area is about 3.9. Here is 395 in terms of lumen area. And the minimum lumen diameter is 1.9. And you are using orbital that is 1.2. And this is very important to measure the lumen when you are sizing. And for orbital, of course, you have only one choice. For rotational atherectomy, you have a multiple choice. Here you can see the starting effect of orbital. At the bordering of the calcium, you can see this rounding shape area that was probably the effect of orbital atherectomy. And you started to see also some thrombotic masses. They are platelets in origin. I'm gently moving, and you can see here the effect much more clear of the smoothing of the orbital. And then going back, you started to see much more thrombus. We said at the beginning, this is a mixed case where you have advanced calcification, but you have also a lot of fibrotic plaque, and you can see also fibroatheroma. Here you have possibly macrophages, very high intensity and shadowing signal. All this is thrombus inside. And you can recognize very quickly also in the different segment of the vessel where you have a small, I think they are going to be here also. You can start to see small masses of thrombus at this point. This is very relevant.
Let's say ACT was normal, let's say going therapeutic levels, and he was pretreated with aspirin clopidogrel
Okay,
for many days.
the first action is let's check the ACT. The second action, because you are treating patients, they are prothrombogenic many times. Also, if you have a normal OCT, when you start to see all these thrombotic masses is, number one, optimize the lumen, number two, react with the small molecules, because that could be a problem for the patient. So here we are still very limited in lumen. We achieve some partial results, and then can tell us what was done later.
Yes. Then we have been okay with that, and did pre-dilatation with a 3.0 non-compliant balloon with good, with a nice result, and then we went to put two stents, 3.0 to 48. Here it is, and then one other polymer-free DES, 3.5 to 12, according to our sizing with the OCT. And we have this peculiarity at the origin of the vessel, but we imaged that it was of adequate lumen, it was above 5 millimeters square. And we had an imaging post-stent dilatation. Could you show there was just an area of malapposition?
Okay, two things. Number one, when you scan the vessel, always try to use it with the OCT or IVUS. Try to use all the information from the beginning to the end. In the end, if must be included the left main. That is definitely, it must be included the ostial of the LAD. Here there was some sort of reduction of the lumen in the proximal part. So it's very, very important.
It's an next pullback. It's a next pullback. And a small dissection there, but you can show this.
We have time to see only one pullback, so choose the best one.
The last one.
The last one.
The last one. It's not.
Is this one?
No. You have to scroll. I think
there are more.
11 and 4.
Wow.
Or 11 and 12.
Wow.
11 and 12. The last one.
So if you are concerned about the pullback before, during the procedure at the end, it was mentioning. Now we are. Got
there it is. It's after post dilatation.
Okay, let's go here. Very, very clear evidence of the value of the longitudinal. Here is the catheter that is automatically detected. Then you are going into the left main. You can see that the left main is a little bit funnel shape, doing this way. This is the polygon of confluence. This is the origin of the circle. Here you can see that at the origin of, at the distal left main, you still have some plaque. Dejan was telling you before that it is impossible to nail the ostium, and the plaque is going a little bit behind. But in the left main, the distal left main is anyway 9.81 millimeters square. Forget about that. But you can see the pathology here. You can see the fibroatheroma. So very important lipid treatment. Then we are going to the ostium. This is the number 8. Here is the ostium of the LAD. Watch it to the catheter. And the area is becoming 481. So if you decided to treat this vessel, you needed to go back, for sure. Otherwise, you are living with an aggressive anti-lipemic drugs therapy. And here you can see proximally.
It's just at one point. It's very. I think we should let that. What do you think?
I think so.
Okay.
Then we have another information that you are seeing.
You have this
from 11 o'clock to 2 o'clock, from noon to 2 o'clock. There is a small dissection. But you can see that the strata are also covered. It's a small hematoma beside, but it's not going back at this point, and it's much better to leave.
And also there was this ulcer before the ulcerated plaque.
Correct. And you can see the previous ulceration that they have at this point. It was a mixed pathology. Then going back, this is a branch. You are just adjusting this to get a little bit better the lumen profile. You are turning the axis to see the branch. Here you have a branch that is identified by the small dots. And then we are going to have a look to the entire length distally. Here you can see that the apposition, the lumen is more than 5.5, so it seems to be okay.
Just have the last.
May I ask Leonidas?
The last imaging, the last run.
May I ask Leonidas just a question?
Yes.
It was left the ostium on purpose. It was by mistake. I didn't get it.
No. On purpose. We went where we have a healthy endothelium, and we have the option at the future to go for a left main PCI if there is a need.
And you can see clearly.
I'm talking about the positioning of the stent.
Yes,
it was on purpose. It was on purpose there.
On purpose there.
And you can see from the angio in AP cranial that the ostium is clearly reduced, also involving a little bit possibly the distal of left main. But now we have a measurement. Now you know that there is no big retrograde dissection going on, and then you know that there was a plaque and somewhere you needed to land your stent.
I think physiology would be useful here at the end because of this ostium. We discussed this in the previous session, the PREVENT trial, and what can happen. I mean, this lesion that extends from the left main into the proximal LAD certainly does have a lot of lipids. But if the FFR is negative, I would tend to treat it medically, as Professor Guagliumi said, with a lot of anti-lipids. You know, LDL below 1.4 millimeters. Millimoles for sure.
We are going to revisit the first obtuse marginal, the right coronary artery, and so we have the opportunity in a few days to do the FFR for the LAD. So it's something that.
And the lumen was above 4, is that correct?
Yes.
4.8.
We'll listen more about the lipid or the valvular plaques in the next session. Let's thank Dr. Poulimenos, and let's close the session.
Teamwork there.